Yes, it is we have, during the Corona period, we have spent our time quite nicely and thought of doing this course rather than individual classes. And we have 3 more classes to go on. And hopefully we'll be able to finish it. And I shall be discussing, Vijay has nicely told that he was involved in quite a lot of work in Hirayama disease. And it is nice to see him, and he is equally active, and you are looking same, Vijay. Okay. So, so I shall be discussing something about spinal muscular atrophy. And always I would like to see the questions, raise a question. So it might be biased from my side, that is it Hirayama disease is a segmental SMA. This I may be little biased, of course, bear with me. The pioneers who worked on SMA is the Johann Hoffmann, you know Hoffmann disease and Wernicke Hoffmann, and both of them they worked in Germany, Heidelberg, and they are the successor of UPS. We have discussed about the UPS, who discovered UPS point, who discovered myasthenia gravis. In the last class we have discussed, and Hoffmann was the student of UPS. And after UPS retirement, Hoffmann taken over the department. And Kugelberg and Wallander, they were the Swedish myologists and who described the other form of SMA. And it was around the early part of 19th and later part of 18th century. A quite long time, but not as old as myasthenia gravis. And the definition of spinal muscular atrophy is that it refers to a group of genetic disorder characterized by degeneration of the anterior horn cell. This is the anterior horn cell, and because of degeneration of the anterior horn cell, there will be wasting and atrophy of the muscles. And it is one of the commonest inherited disorder. The carrier detection is 1:54. Even people can claim that it may be as low as 1:35. That means if we test in the population, the carrier of SMN gene deletion will get it 1 in 50%. But amongst the live birth, the incidence is 1 in 11,000. Because many people may not be able to survive, they may die just after birth. And these people, before the discovery of SMN gene, the classification was entirely based on age of onset and the survival. And on the basis of age of onset and survival, the 0 has been added recently. Earlier, we learned SMN 1, 2, 3, later on 4 came, and now it is 0. 0 means prenatal occurrence, and they die before 6 months of age. SMA 1, less than, they usually manifest before the 6 months, and they may not be, cannot sit, but they live up to 2 years. SMN 2, they manifest before 1.5 years. They can sit down, but they cannot walk, and they may live up to adulthood. SMN 3, they will manifest after 1.5 years, and they live up to adulthood. And SMA 4 is adult onset, that is more than 20 years, slow progression, and they have normal lifespan. The discovery of SMN gene deletion, it is an autosomal recessive disorder that has come out moment with the Kugelberg and even the Hoffmann and Wernicke. They have seen the familial occurrence, and through the pedigree charting, they have realized that it is as autosomal recessive disorder. But the genetic decoding has been taken after the whole genome project, and in 1990s there were several papers simultaneously, and it has been, the locus has been found in 15q 11.2 to 13.3. This is the place where the gene is located, and in this gene we have 2 major gene. That is, this is the telomeric end. Telomeric, you know that it is the end of the until length of telomere actually thought to be the length of the lifespan. If the person's telomere is shorter, he is likely to die early, and the longer telomere is likely to survive more. This was the interesting observation made, and this is the centromere. SMN gene is situated towards the telomere, and SMN2 is towards, that is a survival motor neuron gene. SMN means survival motor neuron gene, and it is towards the centromere. And there is another gene, this is NAIP, that is neuronal apoptotic inhibitory protein gene, which maintain the health of SMN1 and SMN2 gene. And interestingly, why the SMN1 is more important than the SMN2? SMN1, whatever the protein, mRNA splicing, and ultimately all the gene has to be translated through the mRNA to RNA to protein product. That is the SMN protein. And SMA gene produces 100% functional protein, whereas The SMN2, the protein product, only this is the only functional protein. That means 10 to 15% of SMN2 can produce cerebral motor neuron protein, and that maintains our motor neuron anterior horn cell growth, development, dendritic process, axonal sprouting, and all these things. Therefore, the SMN1 is very, very important. And this is SMN gene deletion found in SMA 0 and 1 as high as 95 to 100%. But in SMA2, it is 88%, SMA3, it is 32%, and SMA4, 0%. And already Vijay told some of our results that we also did not get SMN gene deletion in type 4. And now, how the patient with SMA 0 to 2 who may manifest within 1.5 years, how do they present? They present as a floppy infant. And what is floppy infant? It is a descriptive term for hypotonic infant with or without weakness. And it linked to a rag doll. Rag doll means this is a doll made of clothes, and it is very flexible. You can turn and twist the doll. And the features of floppy infant looks like that. Therefore, it is known as floppy infant. And what is tone? Tone is nothing, the floppiness is nothing but the reduced tone. And what is tone? Tone might be tonic or it might be postural. The tonic tone is in response to high intensity stretch. This is the tonic. And postural tone is because of prolonged contraction of anti-gravity muscle in response to low intensity stretch of gravity. And when the postural tone is depressed, that means the postural tone anti-gravity muscle is depressed, trunk and limbs, they cannot maintain the posture. And then the infant, we say it is a floppy infant. The question is how to know, is the infant hypotonic? Whether hypotonia is central or peripheral, it is not necessarily that all the infant will be hypotonic because of the peripheral cause. In fact, central cause is the commonest cause of floppy infant. Then how to know about it? How to investigate peripheral hypotonia and how to investigate the central hypotonia. I will not go in detail about the central pathology. I will be restricting to the peripheral hypotonia. Now, how to know that infant is hypotonic? That can be through the observation of the posture of the infants that they adapt. Feel the infant by palpating the child or doing some posture, and the resistance of the limb to passive movement. And this is the way we know floppiness. On inspection, what do we see in floppy infant? Frog posture. You can see how the leg of a floppy child is, just like a frog. He is lying on the floor. But see the full-term normal infant, there is flexion of the legs and flexion of the hand, and there is a tone is maintained. And what are the other features? Because of this posture, the occiput will be flat and there will be loss of hair. And there may be dislocation of the hip or joints because the child is too floppy. When we lift, we may not, or we may bend the limb and there may be dislocation because of the mechanical trauma. Now the objective assessment, how to do the floppy testing. We can do ventral suspension and traction response. This is a normal infant. When you do the ventral suspension, you see there is flexion of the leg and flexion of the hand, and neck is little low but not too much. In a premature infant, you can see the head is going down but neck is still flexed and hand is also flexed. But in case of a floppy infant, the hand is hanging and leg is also hanging and neck is going further below. Same thing when we traction, when you pull the child by holding the hand, then in a normal baby will have little flexion as well as hand flexion, and he would like to straighten his back. And in premature also, there will be flexion of the leg and hand will not be that floppy the way you are seeing in floppy infant. The leg is straight, hand is straight, and the whole trunk is this trunk. See the position of the trunk and position of the trunk of this baby. So therefore, this is the objective way one can detect that he is having floppiness. Another test you can very easy in the OPD one, everybody can do it, traction of the hand and feet. Then if you pull the leg in a normal baby, then what will happen there? You cannot straight the way you can straighten in a floppy baby. Same thing with the hand. Hand is little flex. You can see in the elbow, but on the other hand, the floppy infant, the hand is absolutely like a straight line. So this is the way we know that we are dealing with a baby who is floppy. Then another is additional maneuver one can do it. These are the maneuver, these are scarf sign. The way we wear a scarf, that means the elbow goes up to the shoulder. If you flex normally we cannot go beyond this position, beyond the nipple of the left side. But here the elbow is going up to the, similarly, when we try to, the ear to leg sign, one can pull the leg up to the ear. It is not possible normally. And when we hold the baby, it just slips through your hand. So this is the way we know that we are dealing with a baby who is floppy. And this is found in SMA type 1, 2, you will get the floppy infant-like syndrome. They will come like that. And rest of the other disease also can have floppiness in peripheral. I will come to that. The other examination finding is tendon reflexes will be absent. Fasciculation of the tongue will be there if it is a enterohorn cell or SMA. Ptosis will be there if you are dealing with a myasthenia gravis or you are dealing with a mitochondrial disease. Myotonia, if the baby is holding, he will not be able to release. If it is a myotonic dystrophy, again, myotonic dystrophy may present like a floppy infant. Or is there is a dysmorphic feature like Downs or many more chromosomal abnormality. They may also have floppiness, but they will have multiple dysmorphic feature. If more than 2 dysmorphia is present, then one should do the karyotyping because usually they are because of chromosomal abnormality. Now coming to the history, already Bijoy told that history is very, very important. One should take the most important, any hereditary disease if you are seeing, or a floppy baby, the family history, that is pedigree. Pedigree, everybody, because pedigree drawing is a international norms. The line you used, Bijoy will be knowing when we are doing Hirayama, all the way how we have done our pedigree charting. And always the emphasis that learn how to do pedigree because it is an international language. If you do proper pedigree chart, you no need to explain what you are telling. Everybody will understand all over the world. And prenatal history, pregnancy history, maternal factors, fetal factors, birth history, neonatal status, and subsequent history. Looks very exhaustive, but it is very, very important because it is said that no one cares how much you know until they know that how much you care for them. So therefore, every physician has to care for your patient and try to elicit all the points so that they will know that this is SMA is even today in our country, it is an incurable disease because we cannot have so much money to treat our SMA patients. The only thing we can empathize, we can sympathize, and we can take a proper history and give a shortcut diagnosis. Now, how to do the pedigree charting? This is for the students. You might be knowing, but just to recapitulate, the affected male is given like a round shadow and you make the totally black. Unaffected, this is the unaffected, this is the affected black one, and female is drawn as a square. And if it is a proban, you have to give a arrow. If you are thinking that they are carrier, you have to make a black dot inside male and female. And if it is an identical twin, this is the way you should do it. If it is non-identical, then you don't have to give this line in between. And if you don't know the zygosity, give a query in between. And if there is consanguineous union, then we have to make 2 lines. And this is the way people will understand what you are dealing with. And if there is pregnancy, this is the line pregnancy. And if there is abortion, but sex could not be identified, then you can make like this to signify abortion. And if it is a therapeutic abortion, you can write TAB. If it is a spontaneous abortion, you can write SAB. And if it is a stillbirth, you can write the SB. And if we examine personally, one can do a line like that, then one will know that we have examined the patient personally. So this is the way one should draw the pedigree chart so that everybody can understand all over the world. When you send the publications, then if you draw a pedigree, you have to follow these norms. Now the next question is a floppy infant, is he having hypotonia and weakness together, or he is having hypotonia without much weakness? The paralytic floppy infant is usually because of the peripheral causes, like spinal muscular atrophy, myopathies like structural changes like congenital muscular dystrophy, congenital myopathies, muscular dystrophy, mitochondrial myopathy, metabolic different glucose and various lipid storage periodic paralysis also can have hypotonia, and neuromuscular junctional defect like neonatal myasthenia, congenital myasthenia, botulinism, all these diseases can give rise to floppy infant during the first year of life. And the list of non-paralytic floppy infant is exhaustive: central disorder, metabolic disorder, primarily connective tissue disorder, and benign congenital hypotonia. And I will not be dealing much. And because the investigation, the approach for central floppy infant is entirely different, and if that therefore one should know whether it is associated with weakness or not associated with weakness. Then coming to the peripheral cause, this is already I have shown that peripheral causes, what we should do. Paralytic floppy infant investigation choices, we can do the CK level. If the CK is high, then we can think that we are dealing with a myopathy. Then we can do the electrodiagnostic test, nerve conduction study. If it is abnormal, then hereditary demyelinating neuropathy might be there, and one may have floppiness because of that. Electromyography will differentiate whether it is a myopathic or it is a neurogenic changes. If it is neurogenic changes, likely to be SMA, or if it is myogenic changes, then host of muscle disease might be because of that. And if we have a possibility of myasthenia, congenital myasthenia, then we can go for RNA study, and one may get decremental response, neonatal myasthenia, or post-synaptic congenital myasthenia, we may get decremental response. Muscle biopsy HS is not needed except congenital muscular dystrophy, where congenital myopathies, most of the congenital myopathies are diagnosed with the help of electron microscopy. Earlier, it was done even for SMA, but after the genetic analysis available most of the places, now it is not indicated. And congenital myasthenia, again, there are now genetic studies available. Therefore, the neuromuscular junction biopsy and electron microscopy earlier were practiced, but not now, because now genetics is coming in a big way. Now the facts and fallacies of CK. High in, one should remember, if there is a asphyxia during the live birth, during the birth, the CK may go up to as high as 1000. So therefore, if you do CK immediately after delivery, if it is very high, please repeat it after 1 week. Then high within 24 hours since postpartum. After delivery, because of the pulling and pushing, the child may have little higher level of CK. Then collect sample before EMG muscle biopsy. And mild elevation of CK can have even in SMA, so one should be aware about it. And normal in metabolic myopathy and congenital myopathies. So therefore, the CK usually elevation means one, by dictum, it is a myopathy. Now, electrodiagnosis in floppy infant, the parents should be explain about the test, because looking at so many machines, they might be scared. If they are the first baby, they may not like to expose their child with needle and pricks and whatnot. So therefore, one should counsel them. No sedation should be required, and nerve conduction has a special precaution is needed because legs are too small. It is a very short limb. So reference value, so usually the recording I will tell you, and 1 centimeter error in the measurement can lead to nerve conduction velocity reduction by 12%. So therefore, the measurement should be absolutely correct, and electrode placement also should be quite correct. And compare with the normal laboratory data, and CMAP 30% in newborn of the adult value and 50% by 1 to 2 months compared to the adult. So that means the 50% of adult value achieved by 1 to 2 months and normal by 2 years. Then median and ulnar motor nerve conduction 50% in adult in newborn. So one should know about it. This is the small baby we have done for our book. The same picture you can get in our book. I request all the students, at least before the class or after the class, go to the book and read. Most of the things are, whatever confusion you might be having, you will be able to sort it out. And this is the way there is a separate stimulator for the newborn, small children. There is a small stimulator, and the electrode placement recording and distally. The leg is too small, so therefore you should maintain the distance, and at the same time the accuracy, the measurement should not have any error from stimulating to the recording side. And neuropathy, although the congenital, your hereditary neuropathy can result in floppy infant, but it is extremely rare. In experienced lab, what they are finding in 10 years, Kennedy et al. Found only 4 floppy infant in 10 years because of hypomyelinating neuropathy. So this is a rare cause. And of course, the decodystrophy patient may have conduction abnormality, but later on they will come out with spasticity. Similarly, electromyography needle examination is important in the floppy infant, because if you get a neurogenic potential, you can go for the neurogenic causes rather than the myogenic cause. Then concentric needle EMG, there is a pediatric size small. The needle we use for facial muscle, that is 26 gauge, 2 centimeter long, is better for neonate or for children. Muscle for spontaneous activities should be vastus lateralis, gastrocnemius, and FDI, because they usually don't move this muscle very frequently. But for if you want to see the MUP, we should do biceps. I prefer to do tibialis anterior and biceps because they will just pull the leg and they will flex the elbow. Then you get the activity and you can get the recording. And activation can be done by tickling the sole or the palm. Then they will try to flex and you can record the activity of motor inert potential. And one should understand that MUP in newborn is shorter, 5 to 10 milliseconds, smaller in size, it is biphasic or triphasic, and recruitment is similar to adult. They recruit fast. Now, what are the expectations when you do the EMG in a floppy infant? If we get neurogenic changes, then it is likely to be spinal muscular atrophy. And in this condition, we will get nerve conduction velocity will be normal, except CMAP might be reduced because of the wasting of the muscles. There will be fibrillation, MEPs will be 10 to 20 millisecond bimodal, and reduced recruitment. Or if we are dealing with a congenital myotonic dystrophy, then we will get myotonic discharges. Or if it is a myopathic MEP, then congenital myopathies, congenital muscular dystrophies, mitochondrial myopathies. And if the child is having, floppy child is having decrement, then neonatal myasthenia or congenital myasthenia postsynaptic may be there. Now, muscle biopsy, I already told it is not very much indicated now. And spinal muscular atrophy, one should look for in type 0 to 2, the discrepancy between social and motor milestone. The child is socially normal. He smiles, he looks at you, even he might be able to speak by the end of 1 year. But there is motor milestone is if it is a type 1, will not be able to sit, type 2 will not be able to stand. So this is the way there is discrepancy between social and motor milestone. Hypotonia, severe weakness, areflexia already told, but sphincter will be normal. And tongue fasciculation, you may get it. There will be pectus excavatum, there will be flaring of the lower limbs, diaphragmatic paralysis, and there will be poor feeding, aspiration, and if because of that, the child may die. And it is already, I told that it is 15q 11.2 to 11.3. And this is where the SMN gene location is there. And it is a homologous deletion because it is an autosomal recessive. So homologous deletion of SMN1 will result into SMA manifestations. And the functional SMA protein in SMA1 is less than 9%. In SMA2, less than 14%, SMA2, 3, less than 18%, and carrier 45 to 55%. Therefore, lesser is the functional SMN protein, more severe is the disease, illness, and early onset and death. And these are the two babies. Both of them are having SMA1, and you can see this is the autosomal recessive. Both are having, there is no vertical transmission, there is consanguinity. Already I told that you have to put 2 lines that suggest the consanguineous marriage. There is consanguineous marriage, you can see there is link in this family. There is a consanguineous marriage, and both the children had SMA and their EMG. You can see these are a very long duration polyphagic MUP. And the SMN gene deletion, you can see that there is no SMN gene in this panel. Both the patients are not having SMN in exon 8. There is no SMN gene is deleted. You cannot see the gene. And SMA diagnostic criteria for SMA, the inclusion we have done, this is your type 3 SMA. So this I will not go because it will be lengthy. Now coming to the flow chart, that if you get a floppy infant, what you should do? See whether the child is having weakness, then it is a lower motor neuron type. And if the child is having floppiness but less of weakness, then it is likely to be central cause. And then we should do the CK. If it is CK is elevated, then likely to be myopathy. Then one can go for either muscle biopsy, electron microscopy, histochemistry, or nowadays one can go for genetic analysis, except congenital myopathy, where you might have to do electron microscopy. Neurogenic on EMG, then likely to be SMA. Then one can go for PCR for SMN1 and 2 deletion. If CK is normal, EMG and NCB, all 3 are normal. Then one may deal with myasthenia gravis or botulinism, one can go for the antibody test, acetylcholine receptor. If it is negative, then genetic, the congenital myasthenia, one can go for the genetic. Nowadays, it is possible. And if it is a central cause, then of course, after examining, we should prioritize. The first step is to do the aminoaciduria, do a CT MRI, karyotyping, and later on, subsequently, based on this finding, one can go ahead with the rest of the investigation. Now, the treatment is available. Now, SMA is no more a untreatable disease. It is a treatable disease. The cost is exorbitantly high at the moment. So how the philosophy or treatment has been generated? The SMA1 you cannot do because it is already, the functional protein comes from SMA1. But SMA1 already is deleted. So you cannot do anything. So what the people are postulating, that if we, the hypothesis is that if we incorporate a functional pre-mRNA splicing, if we use to generate functional protein of SMA protein, then they might do better. And therefore, the nusinericin has been evolved with this philosophy. And this is the nusinericin in SMN2 gene. This is the nusinericin is splicing. The pre-mRNA level, it is spliced, and ultimately there is more SMN functional protein is generated. And therefore, these children are improving. These are the two landmark trials in NEGM. One is very early, one is little later SMA they have tried, and both the children, both the group of the patient, they had better retained milestone, and the deterioration was much lesser, rather they showed improvement. So therefore, this is a ray of hope for the patients with SMA. And if the antenatal diagnosis can be there and just before clinical manifestation, if you can treat, these children might do much better. Now coming to the Hirayama disease. So Hirayama disease already Vijay has told quite a lot, and I will just a glimpse that what is the diagnostic criteria of Hirayama disease. When I was resident in my final exam, in fact, I got a patient with Hirayama, and Hirayama wrote about Hirayama disease, Pinkenbruin, which has come in 1992. That Pinkenbruin came just before my exam, and it was not a known disease during that time. But fortunately, one of my examiner brought a patient from Varanasi to our place. I got the patient. I have seen one patient during my DM regimen, and therefore, therefore, I could diagnose. But examiner thought that how I can diagnose. What should I do? Stay muted. Hmm? Okay. So then subsequently in that, what is the diagnostic criteria? It is a non-progressive oblique amyotrophy. Oblique we say because this muscle recurrently is preserved. So this is an oblique type of amyotrophy. This muscle preserved, but rest of the EDC muscles are wasted. Forearm muscles are wasted except this muscle is. If you see in a semi-prone position, it looks like oblique amyotrophy. And interestingly, it is restricted to C7T1 myotome. Neither it goes up to C6 nor it goes beyond T1. So it is such segmental involvement. Asymmetric onset before 25 years. Progression usually doesn't take place more than 5 years. There is cold paresis, polymini myoclonus. So these are the diagnostic criteria for a patient with Hirayama disease. There are a host of possibilities for the etiology of Hirayama has been, and even now it is unresolved. Is it a ischemic myelopathy because of flexion? Is it a trauma? Is it infection? Is it autoimmune? Is it familial? Is it genetic? These are still the postulation goes on. And when we did the Hirayama disease electrodiagnostic test, there is fibrillation. Fibrillation is less. Very occasional fibrillation you can get, but you get fasciculation, and there is large, long duration, very high amplitude polyphagic potential simulating syringomyelia. In syringomyelia also, you get very giant type of neurogenic potential because of very chronic, long-standing process. And often you will see that in Hirayama patient, they don't know the exact timing when it was started. Somebody else will be saying that your hand is looking very thin. And if you have to probe the history, the scenes when you are having cold paresis, so he doesn't remember. This is the beauty of your chronic neurogenic, either SMA or ALS. There is a chronically the wasting occurs, and even syringomyelia, they may not have very greatly weak. They are like myopathy will be more weaker, but these people have the muscle power is relatively preserved than the myopathy. So therefore, they might be chronic patient, but they may give history of 2 months or 6 months. But if you probe that when you have cold paralysis during winter, you might be able to trace history up to 2-3 years. So this is the way. Then we thought, is it a flexion myelopathy? And about 15 to 20% Hirayama disease patient may have hyperreflexia in the lower limb. Then during that time, interestingly, we got two children who had ischemic myelopathy because of coagulation of water. They underwent operation and cross-clamping time was more, and both the children developed ischemic myelopathy. Then we had some of the thought about, we wrote up those two patients. Then we thought, then Hirayama disease, the lower limb hyperreflexia, can it be because of ischemic myelopathy? As we all know that these are the two posterior spinal artery and this is the anterior spinal artery. And both the anterior and posterior spinal, this is the border zone. And this border zone actually is situated in the pyramidal tract. So if there is some flexion and there is vascular compromise, then this border zone should be involved. And this border zone involvement should result into pyramidal dysfunction. So then we have planned to do the central motor conduction time and H reflex. And H reflex can suggest you excitability of the anterior horn cell if there is a pyramidal dysfunction. In the lower limb, we have done it. But interestingly, the patient had normal CMCT and H reflex, suggesting that motor pathway is not involved, that although the border zone, the pyramidal tract is situated at the border zone. So therefore, we thought that it may not be ischemic myelopathy. Then there is lots of paper you will get that flexion myelopathy in Hirayama disease. Then we thought the anterior cord may not be affected. The posterior tract might be affected because there is always a dural space will be enlarged. There will be venous dilatation. So it may affect the compression over the posterior gall and bladder. So therefore we thought that why not to do the SCP studies. Then we have done SCP in neutral position and F wave. Then what we found in neutral as well as doing the flexion of the neck, we have done median ulnar SCP, median and ulnar F wave. And we have measured the cervical potential as well as the N13 potential. So what we found, the out of 7 patients on MRI, 1 had lordosis, 6 cord atrophy, and posterior during neck flexion, there was loss of dural attachment in 33%, and in one patient had complete loss of dural attachment. And what we found that this is the flexion, you can see the posterior dural space is enlarged, that there may be venous dilatation as well. And that's supposed to produce SCP abnormality if there is a compression, because we got pyramidal tract normal. So now this compression should be able to produce some form of long tract sign. But what happened, their SCP, including N13, N13 is your cervical potential. And this is your APS potential is your N9. And this is the N19 is your cortical potential. Both neutral position, this is the neutral position, and this is the flexion position. And these were normal. That means minimum at F latency, FM ratio, persistent, and chronodispersion, as well as median ulnar SCP potential. So there was no difference between Hirayama disease and control and between neutral as well as neck flexion. And we have postulated that probably this might be the X beta way the ventricle is enlarged in a demented patient. In a chronic dementia, Alzheimer's disease, we get enlarged ventricle. That is a ex vivo effect. Similarly, we thought that there may be atrophy C8 to T1 segment, C7 C8 T1 segment. Because of the cord atrophy, this venous dilatation may be a secondary phenomenon, the way we get in enlargement of the ventricle. But therefore, we thought probably it is not the compression. And interestingly, we got two brothers who had Hirayama disease. And that has stimulated us that is it both, and so far I am yet to get a female with Hirayama disease. All whatever one or two female we have seen, and when we trace them very intensively, they came out to be something else. And these two brothers stimulated us to think about that is it some genetic disease? Is it a segmental SMA? Because then we have done the SMN gene, which I told already, that we did not get SMN gene deletion in Hirayama disease. Because then we thought This is the gel run of those patients. We did not get in Hirayama disease. Whereas in the SMA3, SMA3 both male and females are affected because it is a autosomal recessive disease. And then but Hirayama disease on the other hand is males before 25 years, CAT1 myotome. Is it something to do with androgen receptor? Because androgen receptors are situated in X chromosome. Then we thought of evaluating the X chromosome androgen receptor gene, that is a CAG repeat gene. And it has been shown to be expanded in Kennedy's syndrome. Kennedy's syndrome, all of you know that it is a bulbospinal segmental SMA where there is bulbar weakness, atrophy, wasting, fasciculation, along with proximal involvement, and patient may have gynecomastia, infertility, and it is a young onset disease. And we thought of looking for that. Then we did that study. Again, we did not get significant difference with the control. The CAG repeat sequence were not higher in our HD patient. Then this is the, then of course, then even we could not achieve our, probably this may be able to go through some DNA sequencing or whole genome sequencing, but that is a very elaborative study. Being a clinician, we are not the right person to take up that. Because then we lately Surender was here, and Surender was given, Dr. Surender, he was given during his DM residency. We thought of split hand index has been found to be useful for bulbar ALS. Then we thought of seeing how does it differ from ALS to Hirayama disease. Then what we found, interesting phenomenon. It is the thenar muscle is more wasted in ALS and hypothenar is more wasted in Hirayama disease. Therefore, ulnar to median ratio, that means ADM to APB ratio is more sensitive for Hirayama disease, and split head index, in split head index what we do, the amplitude of abductor pollicis brevis into FDI divided by ADM amplitude. That gives rise to split head index. And this is again goes in favor of ALS, but it's not very sensitive for the Hirayama disease. And the sensitivity, already I told that ulnar to median ratio is better for Hirayama, and for ALS it is the split head index. And it is for HD, it is as sensitive as 80.4 and specific 86.3%, and split index less than 5.2 is sensitivity we found 82%, specificity 88% for ALS, but for Hirayama disease is very less. So therefore, if you want to think of Hirayama disease, go for ulnar to median ratio rather than split index. And to conclude, I would like to say that SMA 0 to 2 present as floppy infant, normal psychological development with hypotonic areflexic weakness, wasting suggests SMA. EDX helps to differentiate neurogenic from myogenic, myotonic dystrophy, and neuropathic or myasthenia gravis. And the etiology of HD is yet to be resolved. There are some more genetic information are coming up, but not uniform. So it needs more elaborate, extensive research on this aspect. And thank you so much.
Thank you. Any questions, comments? I think the main, no.
What is cold paresis?
What is cold paresis? Yes,
okay.
you answer yes.
Okay. Cold paresis, during winter, most of the Hirayama patients, they will say that my hand, I can't walk my hand. The functionality of the hand goes low if they are exposed to cold. And if you want to elicit that, suppose he has come during summer, then you can dip his hand on a ice cold water. That he will not, his weakness and performance of the hand will be lowest. He will not be able to do buttoning, unbuttoning, or whatever he could do, and ask the person to rub the hand. Once it is warmed up, he can do the test. Therefore, when you treat a patient with Hirayama disease, you should ask him to wear a long sleeve and to wear a gloves during winter. The woolen gloves he should wear during winter so that he is not exposed to Hirayama disease.